of this. For one, I think it was year before last, we had early elective deliveries was in this mix as part of the patient safety metrics. Now that's off, and it's all focused on infection control. They added cabbage last year, that was not in there. There's a lot of iterations that go through this, and every year they propose changes and then adopt those changes. And the last 3 years, I believe, we've been weighted 25 all around. But before that, there was like a 30%, a 20%. It got very complex trying to figure out for us to look at what do we need to drive to make sure we get that improvement. So this is the other thing, that baseline, they set baselines, and I'm going to show you that one in a minute, but they are looking at thresholds and benchmarks, right? So the threshold, if you don't at least get to this threshold, you can't play. You get no points at all. This is based on a point system. If you get to the benchmark, that's the highest, you get all the points. The higher the higher the points, the higher we get on the scale, the better chance we have of gaining an incentive. Now, y'all probably can't see much of that back there, but I just wanted to point out to you on the upper left is the safety, and that is all the infection control measures. If you can see what the best is, that's the benchmark. Can anybody see those? They're all 0. We often get asked, well, how can we have 100%? That's what they're asking us to have. That's what they're saying is the best. So every infection that we get, we have to look at. We have to drill into it. Our infection prevention folks, Dr. DePaula really helps us out with this. What could we have done differently? Sometimes, and I think sometimes you'll see that it's because maybe we didn't get a culture on admission. So we didn't need to own that infection. The patient came in with it, but by documentation, we can't tell because we got the culture on day 3, right? So we have to look at every single thing to see how can we get to 0. And for a lot of our infections, we are at that threshold. So some of these are higher is better. So for mortality, they're actually doing a survival rate. So the higher the rate, the better. And then of course, patient engagement, that's patient satisfaction, the higher the better on those. But some the lower the better. So that's going to be your complication rates, the infection control measures, and of course cost. So what do we look like? So value-based purchasing. So this was the iteration. So since 2013, we've been working through this. We started off at 1% at risk, and now we're up to the max, which is 2% risk. Now, I know you probably can't see a whole lot of this. So this is all of the local hospitals. Ruby keeps this graph going. Every year we update it just because we need to look outside of EJ. Are we performing? You know, we want to perform the best, not just as good as, right? So we want to benchmark ourselves to our market and then also to the national. And so I know you can't really read all the numbers, but what you can do is read the graph. And anything above the 0 means we got somebody else's money, as Ruby likes to say. Anything below the line means we lost a little bit of money. And it progresses to the current year. So you can see we had 2 years in this 5-year span where we lost a little bit of money. But the majority of time, we actually gained money through the work that we're doing to improve our quality with partnering with the physicians. Right? And as you can look across the line, we're one of the only hospitals that is consistently performing at the high level. So these are the measures that are currently, this is a little bit of view of it, of what's in the value-based purchasing. Cabbage is the only new one that I have in green down there. The rest continued from last year. Readmissions. Readmissions has 6 conditions that they've chosen. This is anybody who's readmitted for any reason. Not for the same condition, for any reason. So I send somebody home with pneumonia, we think we've taken care of them, they go home, they fall, they break a hip, they come back the next week, guess what? That's in our readmission numbers. Doesn't feel really fair, right? Well, the numbers they're not 0%, thankfully, but there is a national threshold that we have to meet. So these 6 conditions, this is a penalty only, 3%. So what's that 3%? We're now over 1 million at risk for EJ, right? And it can be anywhere in between there. So again, since it's penalty only, you can look at the graph. I know you can't really read those numbers, but the higher the graph, the higher the penalty. So we are, if you look at EJ, which is the first column, we're really outperforming a lot of the hospitals. We have gotten a slight penalty. It's usually on one condition. We had 2 years, I think, running where we had hip and knee. That is an extremely low volume for us. And so just 1 or 2 throws us over the threshold. This last year, it was COPD. And I think everybody would agree that is a challenging population, and the fact that we haven't been hit with that penalty prior to this is probably a statement of how good respiratory is doing looking at those patients and handling those patients. When you look across the state, this is the number of hospitals that got penalties for readmissions. So in Louisiana, 171 hospitals joined us in a slight penalty, right? So nobody's really getting out unscathed. There are lots of hospitals getting this penalty, and I think that was as designed by CMS. Then we move on to the hospital-acquired conditions. Now remember, I just told you all these infection measures, they're in value-based purchasing. They're also in this penalty measure, which is a 1% penalty for us. And this is just a grid. We keep this grid up going as well. This has been in existence since 2014, and you can see the people who have gotten penalties over the years and people who haven't. We have, knock on wood, consistently since 2012, I believe this one started. Oh, so I'm sorry, 2014. We have not received a penalty. That's not by accident. That's by design. There's a lot of effort that goes into that, and working and partnering with you guys to make sure our documentation is correct, to make sure we're doing everything we can. We're trying to look at evidence-based practice. And so this is the observed versus the expected I spoke to a minute ago. You can work this equation both ways, right? We can decrease infections, which is decreased in the actual or the observed, or we can better document on the bottom end of that, right, for the expected. So as I said, if somebody comes in, maybe they came from a nursing home, they already had a urinary catheter in, but we didn't do a culture on admit. We waited a couple of days till we did a culture. So I think that threshold is like 48 to 72 hours. So if we did a culture on day 3 and it came back positive, well then we have to own that one, right? So I just messed with this observed versus expected. But if I had done it on day 1, because I thought, well, you know, they came in with altered mental status and they have a catheter, it could be, so let me culture that. On day 1, that doesn't belong to us, so that puts them in the expected bucket. So my ratio looks better, if that makes sense to you guys. Now, a lot of this comes in with those mortalities that are also in our value-based purchasing. This comes into play when you guys are documenting the comorbidities of these patients. And we hear this, Ruby's going to talk about y'all's dashboards. Every time I get a call about a dashboard, you just can't, well, I don't understand why, I mean, you know, that patient was really, really sick. How did it fall into this population? Well, then we have to go back and look at what you documented and how well the coders were able to pick on what you documented so they could put that patient in the right bucket. So if they can put that patient in the high risk of mortality bucket, you know, they rate 1 through 4. If they can put them in the highest, they're going to wind up in the expected. And you're not going to see that as a negative on your dashboard. All right. So these are just our as Ruby said, every year we have to go through, I don't know, 1,500 to 1,000 pages of all the CMS regs to call out what are the quality metrics that are new for this year. What's coming, what they're taking away, what do they have in mind for us for the future. So we do a lot of, and my quality folks are sitting over there, we do a lot of what they call chart abstracted measures. Where they give us a specification manual, we have to go in the EMR and document according to CMS's specification. So ED, they have decreased that chart abstraction, so that will no longer be covered for this year, but elective delivery and sepsis will continue as chart abstracted measures. On the left column, you'll see all the same hospital-acquired conditions we spoke about before. They're moving some of these from chart abstracted. They're not getting rid of them. They still want to keep track of them. So they've mandated that we figure out a way to withdraw the data from the EMR and send it directly to them. And that's what they're calling ECQMs, or electronic quality measures. So they're moving, like they moved ED2 from a chart abstracted measure, now they've moved it over to an electronic measure. And those new for this year, there's 8 of these, we have to choose 4 to report. And then we have to send all of that data to them on the entire population, not a sample as we do for our chart abstracted. once a quarter, we have to send them that data. And so they've taken away a few. We were reporting the 2 ED metrics and the 2 VTE. So since they're taking away ED, we're going to look at doing stroke 5, which is antithrombotic therapy on the end of hospital day 2. Now coming soon is going to be opioids. I know you guys are aware that everybody is focused on opioids. And so they are going to move to a new electronic quality measure for concurrent prescribing of opioids. And that one's not actually mandated this year, but we're going to start working on it because we expect it's going to be a little bit of a challenge. You have to actually, the computer can't do a chart abstraction, right? I have to say, always go look in this field. The data will always be in that field. So we're going to work on that one so we will be prepared and we can also see our data before it becomes public. All right, so this is our inpatient quality metrics. These are, I guess you could call this a penalty only. CMS still calls these voluntary measures, but it's only voluntary. We'd like to give up 2% of our market basket, so not really voluntary, right? So patient safety still includes our hip and knee complications, PSI-4, which is deaths in treatable conditions, modified patient safety indicators, which these are claims-based measures, so based on your documentation. The stroke mortality, all the coordination of care metrics, and then payment metrics as well. The Joint Commission, they thankfully have aligned pretty closely with CMS. Before, we had different measures we had to do for both, so it created quite a burden on the hospital. So they are, because we have more than 300 deliveries a year, we have to do more than just that early delivery. We're also tracking C-sections and other things they've taken out. I believe this is bloodstream infection for the infants and breastfeeding they've taken out. We also, because we're stroke certified, thrombectomy stroke certified, we have all those measures that we have to abstract each year for Joint Commission. And then the ECQMs are similar to CMS. For outpatient, we also have measures for the outpatient prospective payment system, which is also 2% if we fail to report any of these. And you can see those listed there. The majority of these, some are chart abstracted, but the majority of these, as you can see, are claims-based measures. And others, like left without being seen for the emergency room, we calculate that and submit it through their website once a year. All right, I'm going to let Ruby talk about how they take all of those measures from CMS and put them in a star rating.
Can I ask you a question?
Yeah.
On the now that you're doing electronic transfer of data, is that across, and that's every piece of data you've got? Do you filter that first before you send it, or is it de-identified before it gets out here?
No, it's not de-identified. It has to go through a secure portal in order for us to send it. And the purpose of although we do look at them to make sure that somebody hasn't changed a field that we weren't aware of in the EMR and we thought it was pulling that, but it isn't. But the whole purpose of these is to not have anybody touch them. So they do want them to go directly from the EMR to CMS. And it is through a secure portal and it's not blinded. Did that answer your question?
They have claims.
Well, that's true too. They have all our claims data anyway.
Yeah, yeah.
I guess the big thing about that we worry about is because it does go straight across, is making sure we've got the fields completed accurately. So in the ED, when we're looking at that one, sometimes if we're not documenting in the field that they're going to pull from, it can make our times look bad. So that's why when it just goes across like that, we have no ability. When the quality nurses go through and abstract data, it gives us a little bit of ability to interpret and look in another place. They do have specifications where you look, but it becomes a little bit challenging when it's just going straight across. That's why they have put benchmarks with it yet, because there's variability from hospital to hospital, different EMRs. So on the public rating side, I want to go through these a little bit. So all that data that Donna just went through, whether we're penalized for it or incentivized for it, or just required to report it, they take it. And I love this graph because it really is what it is. They take all this stuff and they say they come up with a star rating. So they can tell the Medicare beneficiaries, is this a good hospital or a bad hospital? Because they say Medicare beneficiaries can understand star ratings, and because when they started putting all this public data out there, people weren't using it like they wanted them to use it. So as our ratings are so strong, I put our January 2019, we are still a 4-star hospital, and it's been under so much scrutiny by hospitals, been argued about. They've changed it so much as far as what they're even included. They've taken metrics out, they've put metrics in. So it's amazing that we maintain the 4-star rating, because some hospitals lost their rating, some gained their rating when they redid it, but since January of 19. But our rating was 0.46. This is a good, you want to be the good side, because the national average is a negative 0.02. So we're very strong there. Slipped a little bit to the 0.22, but like I said, they added things and took things away. So we're still a very strong 4-star, and that's, I said, credit to each of you. And this just kind of shows the distribution. 23% of the hospitals are 4-star, only 6% are 5-star, and then you can see where they fall beyond that. And what's in it, it's all those ratings. It's mortality, it's readmission, safety of care, all of that. And to make it just easy for you, because when you look at these, sometimes the negative is good, sometimes the positive is good, so it takes hours to go through this. We were actually last in January of 19, we were better than the national average on the top 3. That declined a little bit, I think because they changed the metrics. And I always say, if you're not getting better faster than other hospitals are getting better, you're getting behind, because the thresholds are changing too. So we're still doing very, very well. Those top 4 have the highest ratings, so we really focus a lot on those. The 2 that we're below the national average on, with efficient use of imaging and timeliness of care. The timeliness of care is the ER metrics, and there's so much variability in that by region. But the efficient use of imaging, it's going to take years for that to roll off. I know that the radiologists have done a great job. Part of our problem was in the use of with and without contrast for chest. Now it's abdomen, and we've made so much improvement. I think we'll be where we need to be with that. That's what's driving that. So if you really kind of wanted to know, but the radiologists have been working diligently on it. So this is one I just wanted to put together that kind of shows, when you look at one rating agency, it may not mean the same thing to another. So if you look at Leapfrog and you look at CMS, you see where EJ is. We are an A with a 4-star. That's great. That kind of aligns. But what if you go down to St. Tammany's A with a 4-star. But if you look at, I'll look at another one, Tulane, B with a 1-star. I would think that would be, so it doesn't necessarily align, because CMS is all outcome, it's all claims data, but Leapfrog is also structure and process, so we actually put an application. Our file score is an A. And this just shows what's in it, and this is a lot to do with process, computerized physician order entry. So when we drop down to our little B, it's because they changed the threshold for computerized physician order entry from 75% requirement to 85, and we were at 83. So we brought that up, and we're back to our A, but that's what I'm saying, when they change one little thing and how they weight things, and what that means. And I kind of want to point that out, but you can kind of see all the areas where we don't achieve better than the benchmark is on physician staffing. That's ICU intensivist. And you know, we've always had this conversation, and if our outcomes, I have to argue with Leapfrog a little bit on that, because if the outcomes are better in hospitals that aren't, I mean, so is it really the intensivist that's driving it? What's really driving that? But they leave that in there with a high rating, and their staff responsiveness we continually to work on. And this is the outcome measures. There's a few, as Donna said, falls and trauma, and C. diff, and SSI of the colon, which we've got that under control. I have to say kudos to the colorectal surgeons. They did a great job, and it's actually innovation that got that rate way down. And then postoperative respiratory failures documentation. And I know Dr. DeCourty talks a lot about how they're interpreting that, and when you put certain things in the notes, it gets coded as post-op respiratory failure. So you may see that on your profiles. But on the C. diff, we're having to really work on that, and we're putting alerts in. So you may see those where, you know, they're asking if the patient's not actively having diarrhea, we shouldn't be sending a stool sample in because they're colonizing them. So that's an initiative that we have going now. And you can see that we were at a 3.2. If we had been below a 3.15, we would have been a B. And that's how they're rated. There's some things coming up that Leapfrog's going to want us to report, and that's on surgeon volumes. When we look at our volumes, we're doing pretty good in the volumes for our hospital, and they're going to look at surgeon level volumes. And this is just what actually the minimum threshold that they're saying. I don't know why they're still focused on volumes, because a lot of research kind of didn't support that. Surgical appropriateness, I'm just saying for some of the cancer surgeries, we should have a tumor board, which we have, so we need that one. Hand hygiene, we'll have to continue to work on. They're gonna put some new, this is all structure and not necessarily infection rates, but they're saying it has such a big application to infections. But I put this on there just to kind of show the trends. EJ is when I keep talking about the sustainability. We've had strong, we know the one time we had a B was the change in CPOE, and then there was something they put in the alert system that we didn't have turned on in ours. And you can see some of them that they may flip, you know, like Oshner flipped to an A, but now they're back to a B in the fall, and then some that have the other scores. It kind of shows what the trends are. I'm just proud. The only other hospital that's got consistent is St. Tammany, but we've done really well in this. And then when you break it down by the different things, and you can actually go out there because Leapfrog posts all of this, it's always a quandary to me. So when you look at the best hospitals, I put that in the first column, and then you look at East Jeff, the only thing under safety problems, I think, is under pressure injuries that gets most people on that. But we're significantly lower than anybody else except for St. Tammany, and that's the only one that we're not at the best hospital performance. And when I was doing this and I started looking at infections, we have 0, and look at the rest of them. So infections, the way Leapfrog does a lot of process, they weight CPOE and the intensive is so high but not here, and that's a little bit of a quandary to me because what they're trying to do is prevent cost, and infections are cost. So it was interesting on that. And it is the same measures as the C. diff. And so this was one that we put in. You asked, well, what are we doing in the areas that we can improve on? So we had a performance improvement team that looked at it, and what they found was 40% of the C. diff orders were inappropriate. They had a laxative, so yes, they would have loose stools. EMR alerts. So if they're colonized, they're positive because they use they don't use the infection prevention nurse's interpretation, they use the lab tag. So we're trying to do some things, and there will be an alert that's going to be coming up, but they actually studied why our C. diff rates are not going down. Care checks.